After viewing this module, you should have a better understanding of the following: the factors driving the dental care access problem in the U.S., the training requirements, practice scope, and supervision requirements of 4 models currently being used around the country to expand access to care for the underserved, and the different state laws and proposed legislation to authorize mid-level dental providers. For decades, millions of Americans, many of them low income, have been receiving inadequate dental care under a delivery system the Institute of Medicine has characterized as broken. A number of factors create barriers to getting care. Too many Americans lack dental insurance. A maldistribution of dentists across the country means serious shortages in many areas. And few dentists accept Medicaid. In the U.S., low-income children, in comparison to their wealthier peers, are more likely to have health insurance in the form of Medicaid and less likely to see a dentist. And they are twice as likely to suffer from untreated caries. In 2014, more than 47 million Americans live in an area where there is a shortage of dentists, making it difficult for them to access care, even if they have dental insurance. According to the federal government, 6,000 dentists are needed to care for patients in these areas. A 2012 survey of 33 states found that, on average, less than 30% of working dentists filed more than 50 Medicaid claims. There are many reasons dentists give for not accepting Medicaid, including low reimbursement rates, burdensome paperwork, and high rates of missed appointments among Medicaid patients. Federal data reveal that in 2012, more than half of children enrolled in Medicaid in the U.S. did not receive any dental care at all. A clear symptom of the nation's access problem is the high number of people going to emergency rooms for dental problems that could have been prevented. The ER treatment for these patients is frequently a prescription for antibiotics and painkillers and instructions to follow up with a dentist. Care in ERs is inadequate and expensive. A recent study found that between 2008 and 2010, there were over 4 million ER visits for preventable dental conditions. Costs for these visits during this 3-year period were $2.7 billion. A number of states are turning to mid-level dental providers to address their access problems. A dental mid-level provider plays a role similar to a nurse practitioner or physician's assistant in medical care settings. They offer preventive and routine restorative procedures under the supervision of a dentist. There are several different mid-level provider models, each with its own education and supervision requirements and scopes of practice. Mid-level providers are being used to address a number of delivery system problems. Because they cost less to train, both private and public practices are hiring mid-level providers as a lower-cost way to meet patients' needs for routine restorative care. This frees up time for dentists to perform more advanced and costly procedures. Mid-level dental providers are also being used to extend the reach of a dental practice into underserved areas and settings, such as schools, daycare centers, and nursing homes. These providers can perform assessments, prepare and place fillings, and refer patients with greater needs to their supervising dentists. While this is a fairly new idea to the U.S., it is not new to the rest of the world. Mid-level providers have been used for nearly 100 years and are now in 52 countries. An extensive review of the literature done globally on mid-levels finds that they offer safe, effective dental care to children. No study has ever found problems with the quality of care they provide. To offer some context, the growth of nurse practitioners met with strong opposition initially from organized medicine, much like mid-levels in dentistry are experiencing from organized dentistry. Now they are widely accepted in the medical field as members of the team who provide cost-effective, safe, quality care. To address the lack of access to dental care, about 15 states are considering legislation to expand the reach of the dental team. Most of these bills include proposals to authorize mid-level providers, such as dental therapists, or to train hygienists to expand their scope of practice to include some restorative care. For this module, we will examine 4 broad types of models. We will look at 2 types of dental therapist models, where providers are trained to provide preventive services as well as fix cavities. One requires dental hygiene training as a foundation, and one does not. We will also describe a model where hygienists receive additional training in providing routine restorative care, such as temporary fillings, and a new workforce model being piloted by the American Dental Association, a community dental health coordinator, whose main purpose is to educate and refer community members with oral health needs to dentists. Dental health aid therapists, called DHATs, were authorized to practice on Alaska tribal lands in 2003. They were deployed to provide basic dental care to remote Alaskan tribes. As of 2014, 27 DHATs were working in Alaska. Bills have been introduced in Kansas and Washington to authorize the providers. A bill was also introduced to authorize DHATs only on tribal lands in Washington. Dental therapists were authorized by Minnesota state law in 2009. They were created to provide routine preventive and restorative care for underserved populations. As of December 2013, there were 26 DTs practicing in Minnesota, primarily in nonprofit clinics. There is a 2-year post-high school training program for DHATs. DHATs can conduct exams, prepare and restore and non-surgically extract decayed primary and permanent teeth. Dental therapists in Minnesota have a somewhat smaller scope of practice. They are not allowed to conduct exams and have to undergo considerably more training that culminates in a bachelor's degree. Unlike Alaska DHATs, dental therapists in Minnesota can only perform restorative procedures with a dentist present. It's important to note that as of September 2014, the only training program for dental therapists in Minnesota, based at the University of Minnesota, has closed and is being replaced with a non-hygiene-based advanced dental therapy training program. Advanced dental therapists were authorized by Minnesota state law in 2009, along with dental therapists. Both provider types were created to provide routine preventive and restorative care for underserved populations. As of February 2014, there are 3 ADTs practicing in Minnesota, primarily in nonprofit clinics. In 2014, Maine became the 3rd state in the union where dental therapists can practice. The legislature authorized dental hygiene therapists as a financially viable way to expand access to care to people in the state's underserved areas. Advanced dental therapists in Minnesota have the same scope of practice as dental therapists in the state, with some additions. They can do treatment planning, oral evaluations, and non-surgically extract permanent teeth. Advanced dental therapists are required to have a master's degree and complete more clinical practice hours than dental therapists, and can perform restorative procedures off-site without a dentist's presence. Dental hygiene therapists in Maine have a similar scope of practice, as do advanced dental therapists in Minnesota. They complete fewer years of training and can only practice when a dentist is in the same office. Developed by the American Dental Association, the Community Dental Health Coordinator model is designed to offer oral health education to underserved communities and link residents in need with dentists in their communities. 6 states, Arizona, California, Montana, New Mexico, Oklahoma, and Wisconsin, hosted pilot programs which trained 34 CDHCs. New Mexico authorized the providers in 2011. Bills have been introduced to authorize CDHCs in Illinois and Vermont. CDHC training takes 18 months. CDHCs ideally work in the communities in which they reside so they can establish trusted relationships with residents and impart important oral health hygiene skills. They're also designed to help community members navigate the oral health care delivery system. Dental hygiene is evolving. Over time, states have authorized small scope expansions that include non-invasive restorative care, where providers can use hand pieces but not drills to complete a filling. Numerous states allow hygienists to perform at least some restorative duties with the appropriate training. As an example, the Forsyth Kids program in Massachusetts uses hygienists to deliver care to children in daycare centers and public schools, offering glass ionomer fillings when needed. The Virtual Dental Home is a demonstration project in California that uses hygienists to provide care in daycare centers, schools, and nursing homes. They can also practice interim therapeutic restorations. Legislation is pending in California to make this scope expansion law. Supervision for dental hygienists with restorative training is typically direct or general. Expanded functions vary by state, but can include placement and removal of interim therapeutic restorations and fabricating temporary crowns. There is considerable variation in scopes of practice between the mid-level dental provider models. There's quite a bit of overlap, and more years of training does not necessarily result in a wider scope of practice, as the DHAT model illustrates. Dental therapists with hygiene training have a wider scope of preventive services. Of the provider models examined, only dental hygienists with restorative duties and community dental health coordinators are not allowed to drill teeth. None of the mid-level providers have prescribing rights. Length of training varies depending on the mid-level provider type. It ranges from 18 months for the Community Dental Health Coordinator to 6 years for the Advanced Dental Therapist in Minnesota. There is currently no uniform standard on length of training for dental therapists. Both DHATs and Advanced Dental Therapists in Minnesota can create treatment plans, prepare and restore decayed teeth, and work in a different location than their supervising dentist. DHAT training is 2 years, and ADT training is 6. In 2014, the Pew Children's Dental Campaign released case studies on how mid-level providers are operating in private practices and public clinics. The studies focused on how the providers are integrated into the dental team, the types of procedures they're performing, how they're being scheduled, and how their presence may be changing the procedure mix of their supervising dentists. Main Street Dental Care is a small solo practice in Montevideo, a small rural town in Minnesota with an active patient base of about 2,750 people. In 2011, the practice hired a dental therapist 3 days a week. A little over 60% of the patients she sees are on Medicaid. The dentist conducts all patient exams and determines the treatment needed. The DT saw about 5 to 10 patients daily, doing mostly restorations. The Battlefords Dental Group is a private practice in Saskatchewan, Canada that has been operating since the 1960s. In 1980, the owner hired a dental therapist, and in 2009, he hired a second one. These dental therapists are also trained in hygiene and perform both kinds of procedures and are paid on commission. While dental therapists in Saskatchewan are allowed to assess patients' needs and create a treatment plan, in this practice, the dentist conducts all patient exams. Nearly all of the restorative work conducted by the dental therapists is fillings. Norton Sound Health Corporation in Nome, Alaska has dental health aid therapists permanently stationed in 3 of the villages that used to have no regular source of dental care. In the small village of Shishmaref, the DHAT provides preventive care and oral health education to children at public schools in the morning. In the afternoon, he treats children and adults at the community health clinic. Another DHAT at the Hub Clinic in Nome sees patients for checkups and routine restorative care. She travels to remote villages about 11 weeks a year. The People Center in Minneapolis is a federally qualified health center serving a large Somali refugee population. Most patients are covered by Medicaid and other publicly subsidized insurance programs. Faced with a high demand for routine restorative services, in 2012, the FQHC hired a dental therapist to serve more patients. The Virtual Dental Home is a demonstration project running in sites throughout California. Dental hygienists conduct screenings and serve patients in community settings such as schools, Head Start programs, and nursing homes. These are patients who normally don't get to see a dentist. The hygienists collect information and send it electronically to a supervising dentist who creates a treatment plan. Using this technology allows them to be off-site while still supervised by a dentist. The hygienist provides screening and preventive care, temporary fillings, and referral to a dentist for more complex needs. Researchers have begun to study the economic impact that mid-level dental providers are having on the practices in which they work. Information is available from private practices and public clinics. For instance, Main Street Dental Care, the private practice in rural Minnesota, changed the way it did business in the first year of working with a dental therapist. Its Medicaid patient population grew markedly. The supervising dentist was able to spend more time doing advanced procedures, and his practice saw a small increase in profits, about $23,000. This is notable given that nearly 40% of patients seen were on Medicaid, which, in Minnesota, pays 41% of Main Street's customary fees. For the Battleford's private practice in Saskatchewan, in 2012, combined collections from the 2 dental therapists totaled nearly $530,000 in Canadian dollars. After subtracting their commissions and overhead, the dental therapist yielded the practice more than $200,000. In 2013, the research and advocacy organization Community Catalyst released a study of dental therapists practicing in Alaska and Minnesota that found that they cost their employers less than 30 cents for every dollar that they bill. Health economist Mary Kate Scott's study in 2012 found that for Alaska, DHATs more than cover their cost of employment if collection rates for commercial insurance and Medicaid are above 50%. Data collected by the Alaska Native Tribal Health Corporation, the organization that trains Alaskan DHATs, found that typically DHATs bill $150,000 to $250,000 per year more than the cost to employ them and their assistant. The avoided patient travel cost from rural villages to dental clinics in larger towns for care needs is more than $40,000 per year per DHAT. For the FQHC in Minnesota, the dental therapist brought in $30,000 more in Medicaid collections than her costs of employment. This figure does not include any revenue generated by the 600 visits she conducted that were not covered by Medicaid. Right now, the Virtual Dental Home demonstration program in California is grant funded. Here's the economic scenario if it could bill Medicaid for services. Because California has one of the lowest Medicaid reimbursement rates in the country, and dentist and hygienist salaries higher than the national average, the program would need additional funding. If wages and reimbursement were closer to the national average, the program could cover its costs by billing Medicaid for services delivered.